Hello, listeners. Welcome to Doc Talk Live. Doc Talk Live is a health show brought to you by Dallas Renal Group and Zyga Healthcare. The goal of our program is to educate listeners every week on different health topics. We do so by bringing in experts in the medical fields to answer your questions. We are live on Facebook every Wednesday evening at 5:30, and we can also take your questions live from 5 p.m. To find out more about the show, you can log into our website, doctalklive.com. We are also on all the social media platforms, YouTube, Twitter, Instagram, and Facebook. And you can also listen to a podcast on iHeartRadio, Spotify, and Apple Studios. Okay, and today we have with us Dr. Lindsay Van Dyke, an expert in diabetes care. And today we're going to be talking about comprehensive diabetic care. Before we get started, let me tell you some statistics about diabetes. According to 2020 National Diabetic Statistics Society, about every 1 in 10 Americans have diabetes mellitus. And in 2017, diabetes was the seventh leading cause of death. So I think it's very important for us to get to know about this disease, and that's why we have the expert with us today, Dr. Lindsay Van Dyke. Dr. Van Dyke, welcome to our show, and thank you very much for volunteering your time to be with us today.
Well, I very much appreciate the opportunity.
Thank you. Before we get started, could you tell our listeners a little bit about yourself, where you practice, and what is your approach to diabetes?
Yeah, so I am dual boarded in internal medicine and endocrinology, and I have a solo practice in Mansfield called the Advanced Institute for Diabetes and Endocrinology. And the cornerstone of what we do really is diabetes comprehensive care. And really the point of that is to educate patients that diabetes isn't just about sugar, it's not just about insulin, and it's not just about the effects that people are familiar with on their eyes or their kidneys. It's about the entire body and making sure that we are mitigating all of the risks involved so that they don't end up like their grandparents or other family members they knew who had dialysis and all of these other major problems.
All right, thank you, Dr. Van Dyke. So before we get started, what are the different types of diabetes mellitus? Can you tell the listeners what is type 1, what is type 2 diabetic means?
So there's several types of diabetes. So type 1 simply means that the body cannot produce insulin anymore because of an autoimmune condition that has destroyed the pancreas's insulin producing cells, the beta cells. And there is a similar condition that we qualify as a type 3 diabetes where they've had otherwise pancreatic destruction from surgery or other disease where they can no longer produce insulin, and that's not autoimmune mediated, but it does require insulin. And then type 2 is a much trickier, much more complex scenario that has problems that are in the kidneys, they're in the pancreas, they're in the muscle and the brain. And we call all of these things that mix together the ominous octet of diabetes physiology. And so that's why there are so many different kinds of medications to manage that kind of diabetes. There are a couple of other subtle types of diabetes. You can have diabetes onset in pregnancy, that's gestational diabetes. And then there are some of the rarer ones, like we call them monogenic diabetes. They're kind of inherited and they follow a slightly different kind of course. They tend to be a little more mild than your usual type 2.
Oh, all right. Very good to know. I didn't know about type 3 and monogenic. Something that I learned today. Good to know, Dr. Van Dyke. So how do people get diagnosed with diabetes? Like, is it by a blood test, or how do we, is it risk factors, or if I have a family history, how do we get started? How do we get diagnosed, the first step?
Well, we always want people going to their primary doctor for screening once a year. And there are different preventive care guidelines and task forces that say how frequently, at what age you should be screening people for diabetes. Some people have very dramatic diagnoses where they have kind of this explosive critical event that lands them in the hospital. And that's diabetic ketoacidosis, or a condition that's similar to that. And you have to stay in the ICU and you have to get insulin, and it's a crisis. Other people are detected earlier. They're detected with an A1c screening at their primary doctor's office, and they find out they have pre-diabetes, or maybe they have an extensive family history and they know to go get checked, and they pay attention to those details early and try to prevent it. Type 1s tend to be the ones that have that really dramatic diagnosis, because they're usually doing fine, and then kapow. They have everything kind of give out on them, and then they have diabetes.
Okay, gotcha. So are there blood tests that we do to find out about the diabetes and stuff?
There are several blood tests. I mean, people stick their fingers. That's called a capillary glucose test. That'll tell you what your blood sugar is. You can wear a glucose sensor that will check the tissue under your skin every so often for blood sugar readings. There are, you can have the blood drawn and check a glucose level, which is the most reliable way to see what your blood sugar is doing. The hemoglobin A1c has been kind of our landmark test for many years, and that will probably no longer be the case soon. But what it does is give you about a 90-day window as to what the body has been experiencing in terms of the magnitude of sugar in the bloodstream. And there's a similar test called fructosamine that works the same way, but instead of using hemoglobin, it's checking proteins in the liver for that same kind of amount of sugar, and it gives us a little bit different window, like a 2 to 4 week window.
Okay, gotcha. So both are blood tests?
Both are blood tests.
Gotcha, okay. So now that we talked about the diagnosis, the next step, I guess, would be the treatment options for diabetes. And I'm sure there are lots of different things that we see in advertisements in TV, pills, new types of insulin, where they say you just inject yourself once a week and you're controlled. Could you explain to our listeners about the different treatment modalities that you use, and what is available in the market, and what is the new things that's available?
So let's talk about type 1s first. So as we said, type 1s have to have insulin. Insulin is one of those hormones that you must have in order to live. And they can take that in injections. They can take that subcutaneously as an infusion in an insulin pump. That's kind of the standard of practice for type 1s, to have an insulin pump, because we can really customize it to mimic what the pancreas would be doing otherwise. People's insulin sensitivity does evolve through the day, the same way that blood pressure will evolve through the day. And so a pump can make up for that. A pump can say, well, we know from your sensor data that you have more resistance in the evening, and so we'll adjust your rates during the evening. Or it's normal to have a surge of cortisol in the early morning hours, and some type 1s have a real problem with that. We call it the dawn phenomenon, and the pump can see that coming and make up for it. There are smart pens for delivering insulin that we can program in many ways to behave very much like a pump, and it will do the math for the patient, and it will keep track of the insulin, how old it is, how warm it is it effective? And then there are insulin patch pumps. We usually use those for type 2s because they're not very, very precise. You can only administer more than 20 units a day of basal insulin, or you can only, each click that deploys insulin at a mealtime was going to give 2 units at least. And so, but the point of that is you put one of those patches on, it's one shot to put that on, and then that whole day it's going to trickle out a little bit of insulin for you, and you click the button to administer at the mealtime. So it's a lot more discreet, it's a lot more convenient, and you get better compliance with those kinds of devices. So that kind of covers type 1, and in most cases the type 3s that we run into. Now for type 2s, the world is your oyster. I mean, we just have myriad medications now, and I always tell patients, this is not your grandma's diabetes. The things that you're afraid of that you saw happen to your grandma don't need to happen to you, because we are dealing with a whole different level of technology than grandma had. And so metformin we've had forever,
Yep.
And we have such a great safety profile on metformin. That's our cornerstone. That is awesome. It's my all-time favorite medication in all of medicine.
Mm-hmm.
And I did my fellowship research on metformin.
Yeah,
And it's dirt cheap. It's awesome.
that's good. Yeah. Mm-hmm.
So metformin is one class of medication. Now, I approach type 2 diabetes with my trifecta, backbone medications. And metformin is the first one.
Mm-hmm.
The second one is a class that utilizes the kidney's ability to either hold on to sugar, like evolution wants us to do, or get rid of it.
Mm-hmm.
And it kind of tricks the kidney into dumping sugar out. And so we get all these other benefits from that. You get a little bit of weight loss. Recent data shows we're getting protection against developing kidney disease
Yep.
from
Mm-hmm.
diabetes. You get a little bit of a blood pressure benefit.
Mm-hmm.
You get protection against heart failure. And I think that so many patients and even physicians aren't really aware that the risk of heart failure without having a prior heart attack in diabetes is like 50%.
I know. That's
It's
right.
enormous.
Sudden cardiac death, correct? Mm-hmm.
Yeah, and so we have medications like that that really pay off. The investment now is the payoff is so big 1 year, 5 year, 10 years from now. And then the third component of my trifecta is another class of medications that patients are familiar with from commercials like Ozempic or Victoza. And that class gives us some long-term cardiac benefits. It also helps promote their weight loss because it's a hormone that's produced in the gut anyway. And so when you boost that level of hormone with that medication, patients have smaller appetites. They tend to lose more weight, which then, of course, potentiates their insulin sensitivity. And, I always tell patients that you're kind of the captain of the ship here. There's nothing I can do for you that's as good as what you can do for yourself, namely lifestyle management, being active. If you're able to promote 5 to 10% of your baseline weight loss, that is killer. It's awesome. And so that should always be primary and everything that I'm doing secondary. Now, not everybody wants to do it that way. And I say that's cool because this is exactly what the big guns are for. We have concentrated insulin. We can use concentrated insulin if we have to. But I think it really motivates them to know that we can make choices that make sense in other aspects of their life and wellness. And if we're aggressive about it now, then their payoff is great later. Yeah. And then they don't have these long-term consequences like people used to have in previous generations.
Yeah. So this is you have talked to us about the medications, different things available. What about diet and lifestyle? They also play a key role. That's what we're saying, right?
Yes. So, like I said, it's the cornerstone. It's always going to be the cornerstone, especially for type 2s. And so we have made arrangements in our practice to make sure that we can get patients plugged in to dietitians and CDEs. And that can be really hard to find. Absolutely. And so we wanted to make sure when we set all this up that patients in the community, they don't necessarily have to be our patient in order to come see the dietitians.
That's very nice.
Right. So we partnered with Dietitians of Dallas in order to pull that off. And so we're seeing our own patients there, and then they're seeing anybody in the community that needs to come.
That's a great service because the diet is, even my patients, doctor, what can I eat? That's always there, and if some patients show motivation, I think the dietitians, that's a great service that you have, Dr. Van Dyke.
Well, and it helps, they have another access point because it can be really hard sometimes to be able to get in and see the doctor again. And, I wrote all of our own patient education materials because I felt that the stuff that was out there was just inadequate. It wasn't answering people's questions. Yeah. And so I wrote our own library to specifically address the stuff I kept getting asked over and over.
Again. That's right.
And in there, I give them a list of foods that help them make better choices. But I mean, I just gleaned that information from my own personal experience. I'm certainly not the expert in diet, and so that is appropriate to have someone else be brought in to deal with that.
That's good to know. That's dietitian service is excellent for the patients. Yes. One more question. Once you become a diabetic, you're a diabetic lifelong, correct?
Not always.
Not always. Oh.
I mean, so if you get type 1, then so far we have no gene therapy to be able to bring those pancreatic cells back, and you're kind of stuck that way. But again, early detection and aggressive intervention in those early phases is really the key to your future. And so I love it. If pre-diabetes patients are coming to me, I love it because we're very aggressive. We will apply the same kinds of comprehensive management strategies in pre-diabetes because that's where you can actually turn it around.
Okay.
And so we know that diabetes is inherently a progressive process. And if you are diagnosed in pre-diabetes, you have this opportunity to, again, optimize the lifestyle, drop 5-10% of your baseline weight, and that's going to dramatically improve your insulin sensitivity. And so if we can hold somebody in the pre-diabetes phase or get them back into the normal phase of their A1c and we can keep them there for several years, then we can tentatively treat that as a cure. Of course, you don't have the freedom to go regain and redo all the stuff that people do. But it's very possible, and I'm a proponent for medication in in pre-diabetes.
Yeah. Okay, that's what I was going to ask you. So is Oh, okay.
That's typically the first thing that goes awry. And we know when those kinds of derangements begin to happen, we've already had a problem with about half of our pancreatic beta cell load.
Okay.
And so it's very, very important that we are dramatically making efforts to decrease the blood sugar in that phase and allow the body to recover from that inflammation as much as possible.
And you use medications for pre-diabetes?
Metformin's my favorite for that. Now, there's also data that says that pioglitazone, another old drug that's been around for a very long time, is an extraordinary insulin sensitizer and is implicated in preservation of pancreatic function, as well as the kidney drugs that I had mentioned previously, the medications like Farxiga or Invokana or so on. And then there was data that came out about that third class that I love so much. Victoza specifically was implicated in pancreatic preservation when it was used early in the course of disease.
Okay, all right. So with diabetes, they say that it affects the heart, the eyes, the kidneys, and the nerves and stuff. So let's first start with the heart disease because we see a lot of cardiovascular disease and stuff. So what would your thoughts and prevention for the patients with diabetic heart disease and stuff? How do we prevent those?
Boy, and that's a loaded topic. So I think we kind of have to back up a little bit and acknowledge heart disease being the number one killer, at least until the latest COVID surge, was the number one killer in the United States. And it kills on average one individual every 60 seconds. Wow. If you are counting strokes as well in that, we're talking about a death about every 45 seconds. So we're losing well over 500,000 people a year from something that is almost entirely preventable. And it just kind of keeps going back to the same theme over and over, that if you're paying attention early and you are aggressive early, this does not need to happen.
Yes.
So how does diabetes cause heart disease? First of all, the cholesterol problem. Cholesterol deposits, or atherosclerosis, it's mediated all by inflammation. It's all inflammatory processes that cause that stuff to be laid down in the vessels and then eventually destabilized. So if we're able to control the inflammation, we are treating in a way that underlying cause. Diabetes, when it's allowed to progress or it's allowed to go uncontrolled Then we have problems of the blood sugars themselves kind of chipping away at the integrity of the blood vessels. And where there's damage to vessels, we get formation of more plaque, we get formation of platelet products and blood clots, and you can run into trouble just from that process. Usually people who have diabetes also have metabolic syndrome, which involves high blood pressure, and we carry fat kind of higher up in our trunk that affects the organs more, and all of those individually play their role in heart disease formation. And so here's the thing that I do. The most valuable test I use is the coronary calcium score.
Okay.
And if I have a type 1 who's had diabetes for at least a decade, I'm going to get them a coronary score.
Okay.
Their risk is not as bad as a fresh type 2,
Okay.
but they've had ongoing inflammation for a considerable period of their life, even if they're still young.
Yeah.
And what that scan does is it's just a CAT scan of the heart. It's looking in those teeny coronary vessels for calcium deposits, because if you see them, you know you've had long-standing atherosclerosis. If we see that, if we have somebody coming back with a positive scan, then we're going to be as intense about that as we would be with someone who's had a heart attack. But we're going to keep them out of the hospital.
Absolutely.
You know, it's $100 scan and cheap medication and lifestyle adjustment, or it's a $50,000 stent or surgery.
And then the long-term implications. So it's just like what you said, you have to act right then.
Act right then. And the thing that I love about the scan as well is you get surprised sometimes. You'll be like, oh my God, this guy's only 28 and he's got 2 calcium spots in here.
Okay.
So it kind of gives you a clue about their family history. Or another population that has this problem are cancer survivors, people who've had radiation therapy to the chest. You run a coronary score on them, you're probably going to see calcifications on that anterior side of the heart.
All right. One more thing, Dr. Van.
That diabetes will kind of chip away at the integrity of the vessels. It's doing the same thing with the nerves too. And that's happens in the kidneys, it happens in the eyes, and it happens in the fingers and toes. So usually you have to have long-standing hyperglycemia, uncontrolled diabetes for some period before this becomes obvious as a problem. Can we prevent it? Yes, with excellent control.
Okay.
Can we get sensation back after we've lost it? Not very often. Usually once it's there to stay.
Okay, gotcha.
Yeah.
I mean, as you said, diabetes is so vast, it affects almost every organ in the body. So it involves comprehensive care, the correct title that you put, like you have to have
Idea is, number one, we handle the education part. They have tutorials they watch. I assign them homework so that we can all be on the same page, right? And usually people are learning something new in that. And I have it set up so that they can do it from home on the web, and they come back with their questions and we fill in any blanks. We get them the right referrals. We make sure that they need to see dietetics, they're going to see them. They're going to get the referral to the eye doctor, the foot doctor. They're going to get their scans and their screening. And just like the heart, we got to screen the bones too.
Okay, got you.
And we cover immunology. They need their vaccines.
Okay, that's right. I mean, now the latest, the COVID, they are at increased risk for COVID and stuff. So
Phase 1B.
That's right. I mean, you've given us a good nutshell of how to take care of diabetes, what it affects and what it needs and stuff. And we are approaching towards the end of the show. Any last minute advice for the listeners and a little bit about your practice before we would wrap up the show?
Yeah, I think you could probably learn a lot if you check out our website. It's aidendo.com, aidendo.com, and there's lots of education materials and links to videos and things that you can learn there. People can schedule appointments or ask questions.
That is good to know.
Mm-hmm.
Oh, that is very, very good to know, Dr. Van Dyke. And your dietitian service and
Yes.
stuff that you have, that's
Yes.
it's actually excellent, excellent. Thank you so much for giving us a nutshell.